The views and opinions of our guests are personal and do not represent their institutions or Applied Prevention Science International.
So good afternoon, morning some places, evening in another places, everyone, and welcome to our 5th Prevention Talk. I am Maria Luna. I'm the director of the Applied Prevention Science International Education Center. Today, we will be talking about what it takes to professionalize the prevention workforce, and this talk will be presented and moderated by Jim Ryan. Jim is APSI's Director of Training. I am going to ask you to please be muted at all times, and that's it for now. I'll pass it on to you, Jim.
Thanks, Maria. Glad to be with everyone today for what I think is a really important topic. Again, our topic today, professionalizing the prevention workforce, has really had an almost omnipresent relevancy since the inception of our field many years ago. As a relatively young profession, we have and continue to experience a combination of both exciting advancements and frustrating challenges as the field develops. When you think about the ever-growing recognition of the scientific foundation of prevention, coupled with a professional community embracing increasingly higher expectations around knowledge, skills, and competencies, have stimulated the field's progression. But degree programs in prevention are few and far between, salaries are often low, and envisioning a prevention-specific career path may seem futile in some areas. Limited diversity within the profession also presents challenges, as does a growing but still deficient recognition of prevention expertise and prevention credentials by other professions. That said, we're making progress. Recognition of prevention science and practice among everyone from educational systems to the general population is growing. And in many parts of the world, younger generations who have been more exposed to prevention than their parents and grandparents ever were are seeing the opportunities for careers in our field. So we're going to kind of wrestle with a lot of this subject matter today and really think about what it takes for us to continue the professionalization of the prevention field around the world. Our 3 panelists will discuss some of these issues and respond to questions from you as well, and we're going to have a good dialogue today. Our esteemed panel today includes Dr. Tracy Flynn, who is our Senior Research Analyst with the National Association of State Alcohol and Drug Abuse Directors, aka NASADAD. Welcome, Tracy.
Glad to be here, thanks.
Thank you. We also have with us Julie Stevens. Julie is a board member of the International Certification and Reciprocity Consortium, again, more familiarly known to many folks as ICNRC. She's also an advisor to the Prevention Committee and member of the advisory board of the National Prevention Technology Transfer Center, PTTC, because we like our acronyms, and adjunct professor, University of Oklahoma's Master of Prevention Science degree. And then our third panelist is Sandra Del Sesto, who is the delegate to and former co-chair of the Prevention Committee of ICNRC and member of the advisory boards of both the Latino PTTC and the National PTTC. So we have a qualified group of folks here today that are really going to take us in some good directions in this conversation. Our process in terms of how we're going to move forward, each of our panelists will kick off our conversation with some thoughts. They're going to share some thoughts about some particular key issues around workforce development and prevention workforce. If you have questions at any point during their introductory comments, please put them in the chat or just hold them until we get through each of their 3 kind of introductory pieces. And then we will just continue the dialogue and conversation. I'll be asking some questions, but we'll also be building in some of the questions that you're asking as well. Again, you have 2 options to do that. One is you can type your questions into the chat feature, or you can use the raise hand icon, and Maria will be helping me to moderate that, and we will either, again, use the questions from chat and or call on folks and let you unmute yourself to ask your question verbally. For the purposes of time, please be as concise as possible with your question, especially if you're not using the chat function, if you're asking that verbally, so we can get through as many questions as possible and keep the conversation going. So with that said, we are going to get started. We really want to hear from our experts today. And so Tracy, if we could start with you, please.
Okay, thanks, Jim. So as Jim said, I'm with NASADAD, which is a private, nonprofit, educational, scientific, informational organization based in Washington, D.C., but we serve the states, territories, specific jurisdictions, and tribes. So our mission is to promote effective and efficient state substance use disorder prevention, treatment, and recovery systems. So I work primarily with the National Prevention Network, and that's a component group of NASDAD, and they're made up, the NPN is made up of state prevention directors. Each state, each NPN in each state, I'm kind of going through this for those who aren't really familiar with NASDAD or with the structure here in the States. So the NPNs in each state work with their respective state agency director to ensure alcohol, tobacco, and other drug prevention services. So the prevention workforce topic is really important. Oh, and I see one of our NPNs. So hi, Susanna. It's really important to the NPNs. It's a big topic of interest. And we even have a learning community that is around this particular topic. So just based on my work with them, I believe that the three biggest challenges currently facing the prevention workforce, one is recruiting new professionals, prevention professionals into the workforce. So, how do you get people to even know about it? Where do you get them from? I mean, I just kind of fell into it a couple of decades ago. So is that like most people? Are they just falling into it? Or, or there are more and more community colleges, bachelor, master's degree, and even a few schools that have PhD programs for prevention professionals. So how do we get new professionals into that workforce? The second challenge is retaining more of the current prevention workforce. So once you get them into the field and trained, are often losing them for many reasons, either going somewhere else within the agency where they can make more money, grant funding, just a whole host of other issues, which I'm sure that we can touch upon today. And then the third one is improving the prevention workforce infrastructure. So in the US, it's not consistent from state to state, whether or not prevention professionals need to obtain their credentialing. And then there's pros and cons to getting that credentialing, because in a lot of states, they're not going to get any additional salary increase. So just building the prevention workforce infrastructure to be more supportive. It's not a job classification in our US Department of Labor job classification system. So there lacks a national kind of cohesive even data on the state of the workforce, but even just some information about how many and salary ranges and things like that. So those are my three.
Thank you, Tracy. Appreciate that. And folks, again, as any of our presenters are speaking, jot down your questions or put them in chat, or again, prepare to ask them when we after we hear these introductory statements. Julie, can you take the baton?
Guess I need to unmute. Right. Well, thank you for having me. And I also want to recognize Marissa Carlson, who is on the training today. She is the ICNRC. Hey, she is the ICNRC Prevention Committee Chair. So she's is pretty new at the job, but she's doing a great job. But what I want to talk to you about a little bit, and Tracy touched a little bit on this, and so it kind of made me think that, there are certain benefits to being a certified prevention specialist. And I wanted to just let you know, it actually, it sets you apart from others in the field who are not certified. And it gives sort of a standard or a quantifiable milestone of achievement based on industry standards and evidence-based practices. We have created this credential, so it establishes a credibility and verifies your competence in the field. It's measurable competence in the field. And it's a marketing tool for you. And, Department of Labor says that weekly earnings of full-time wages and salary workers with a certification or a license is 34% higher than people who don't have a credential. So let me introduce you a little bit to ICNRC. That's the International Certification and Reciprocity Consortium. It took me about 5 years to memorize that because it's easy to say ICNRC, but what does it stand for? So did memorize that, but we've been around for more than 35 years in the field. ICNRC develops the standards and the examinations for the credential, the CPS credential. We also have credentials in treatment and recovery. And these credentials adhere to the highest standards of quality and excellence as determined by the field, and also integrity. It ensures or assures integrity. ICNRC today has about 73 member boards. And so because we have the international designation, it tells you that we have some international regions that are members. We have 11 actually international regions, 48 states and territories. We have 3 Native American regions, Indian Health Services, and all branches of the U.S. military are members of ICNRC. And so they don't all have the prevention credential, but 56 of the boards do have the prevention credential. And anybody from Ohio here, you know, if you're from Ohio, I want to congratulate you because your state has the most certified prevention specialists. And then Texas has the second, which is where I'm from, but lots of them, New York, Michigan, and Oregon as well. So other credentials that ICNRC has includes the alcohol drug counselor, the advanced counselor, the clinical supervisor, the certified criminal justice professional, and peer recovery. And I'm looking to see what I'm going to talk about. But we have actually over 50,000 reciprocal levels credential professionals. And so it is, by the word, the reciprocal means that, you know, if you move from Texas to Oklahoma or from state to state, if the other state that you're in is a member of ICNRC, you can have reciprocity. You have to fulfill their requirements, but you don't have to take the exam again. You only take the exam one time. And how we do a prevention job analysis every 5 to 7 years, which means we have a psychometric company. We don't do it ourselves. I'm not an statistics person, but we have a psychometrics company that administers a survey and does a data analysis from that survey. And that survey, we ask questions like, what do you do? And this is a survey of prevention specialists and maybe some behavioral health specialists. So we ask, you know, the credentialed specialists, what do you do? How often do you do it? How critical and important do you think it is? And from those kinds of questions, our psychometric company determines what we call domains. We also use subject matter experts to help us determine the validity of the questions. And I mean, it's a long, arduous process to get to a point from the beginning of using subject matter experts to the very end where we actually have an exam. And so from the data and from subject matter experts, we determine the domains. And the domains that are currently, we have planning and evaluation, education and service delivery, communication, community organization, public policy, environmental change, and professional growth and responsibility. Now, the interesting thing is that this one was done in about 2013. Prior to that, 2007, we did not have a domain in communication. The communication domain was added in 2013 because all of a sudden we had social media, you know, we had Facebook, so we added and it was important that prevention specialists know how to do the communication piece, public speaking, facilitating groups, and social media, those kinds of things bubbled up, you know, when we did our job analysis in 2013. And from the survey and determining the domains and utilizing subject matter experts, we create the standards that are the industry standards for prevention specialists. So, you know, there are certain, the standards are basic standards. They include 2,000 hours in work experience, 120 hours in education, 120 hours in supervision, passing the exam are the standards. So those are the basics. So our jurisdictions and members must utilize those standards in their credential in their jurisdiction or in their state. So those are the very basic ones. They can add to them. They can add a college degree, you know, if they want to in that state. But those are the minimum standards. And then I'm going to stop here because Sandra has a little bit more to add. So we want to roll it to Sandra.
Jim, do you want me to just pick up
Yep.
from there?
Go right ahead, Sandra.
Okay, hi, I'm Sandra Del Sesto, and I see a number of people that are familiar to me on this call. Welcome. I am the former co-chair of the Prevention Committee, and I've been a delegate to ICNRC from Rhode Island for the last maybe 20 years or so. So I'm going to move on from what Julie told you to talk about the national exam. Once the job analysis is completed, and in the next few months, we'll be starting beginning with another group of subject matter experts to revisit the job analysis, which was done about over 5 years ago, and make some changes. Once that's done and it's drafted, it goes out to 1,500 certified people from the different states and jurisdictions, and they weight the knowledge and skills areas, you know, like using something like a Likert scale, like how important is this for a prevention professional, this knowledge area or this skill area from 0 to 5 years, because that's the exam is focused on people with 0 to 5 years experience. Okay, it's based on the job analysis. Okay. Augustine, mute, thank you. All right. So, so the weights that come back from those 1,500 folks, 1,500 or so, determine the number of questions in each subset of the domain. So if it's rated high, there'll be more questions attached to that. So then another group of subject matter experts develops questions directly based on the materials and the list of references to be used. And those references are listed on the ICNRC website and also on the websites of each certification board. So the references are typically less than 10 years old. There's only one that isn't, and it's the one that references ethics for prevention professionals. And that's only because there isn't another one, and everything in that book, and it's one of the few books that's on there, and it's still published, by the way, are still relevant. So the references have to be easily accessible, most of them with an email link, and less than 10 years old. So once those items are developed, and when we write them, I've been an item writer as well, as has Marissa and Julie. We have to reference a specific page in a specific text. So it increases the validity of the exam, and I'll talk about that. So the items are then reviewed by the testing company and then piloted in a subsequent test administration over time. So the test that people take is 150 questions, but on every one of those tests, there are 25 questions that are not scored, but are part of our piloting of those items. And then they're looked at by the testing company to see how they do. If everybody gets them right, it's eliminated because it's not a good discerner. And if everybody is getting them wrong, or most people are getting them wrong, then those are eliminated as well. So it's a psychometric determination that's made by the testing company. Special accommodations are can be requested by folks with, for example, if they have any kind of disability, but that's through the local board. And all the exams are now taken online, and a person who's applying to take the exam would contact their certification board, submit their application first. And the application asks for supervision, 120 hours of supervision, and documentation of coursework, which is 175 hours. That's on the ICNRC website. As Julie mentioned, individual states and jurisdictions may have increased that. We have a matrix for each state. And actually the PTTC NCO is going to be putting that up online very soon. So you can look from state to state. So in order to pass, people need to be familiar with all the knowledge and skill areas in the job analysis. And they need to study the references that are listed on the ICNRC website. I can also add, because I just asked this question to our prevention Google group, how many states and jurisdictions require the substance abuse prevention skills training. So while that's not on our reference list, the information sheets in the SAPs are extremely helpful for people studying for the exam, as well as the information sheets in the prevention ethics course, which is the only course that's required, specifically required. So a general ethics is not, does not fulfill the requirements. It has to be prevention ethics. And those are available through the PTTCs as well. The exam has 2 versions. So the passing score varies based on the version. And then once a candidate takes the exam, they not only receive their total score, and they get that immediately, but they also receive scores based on the domains. So if they do fail the exam, they are going to know which area they need more study and preparation in. And what we find is those who fail the exam often are maybe delivering a specific prevention program, say a program in the schools, but are not familiar with the strategic planning process, or they are done work at the coalition level, but they don't know anything about evidence-based practice. That's less likely, whatever. So, so navigating the certification process. If someone is wanting to be certified, and there are some states that require certification, like mine, Rhode Island, and Julie's, which is Texas. You would start by contacting your local board. If there's someone on the call where your state does not have, and there are only about 4 that don't have a certification board, you would contact a state near your board, near your a board near your state, like the adjacent state. And then and international applicants can also contact an existing board. So to summarize the requirements, you need 2,000 hours of experience, which is the equivalent of 1 year full-time, but it doesn't have to be in 1 year, it can be overtime. 120 hours of supervision, and who can be a supervisor is determined by the local board. It's not on the ICNRC website. And 175 hours, as I said, of contact work in prevention. 24 hours has to be ATOD specific, and 6 hours must be in prevention ethics. And as Julie said, some jurisdictions have additional requirements. And then once you submit your application, then you're contacted by your board about where to go and how to take the national exam. And as Julie mentioned it, and I'll end with this, the benefits of certification. First and foremost, it's public safety. It's like, are we ensuring that our service recipients, our participants are getting the best program? You know, I always say to folks who object, I'll say nail technicians, plumbers, people in professions, that are less problematic with regard to human subjects require certification. And so there's no argument against this as far as I'm concerned. It ensures or increases the likelihood that there's best practice in service delivery. It increases our credibility, and it also increases the credibility of our field. So turning it back to Jim, I did want to say, Marissa typed in the chat box, we have a planning group that's working right now that includes CADCA, the National PTTC, NAZADAD, Tracy is a member, the ICNRC, and the state of New York, which was the first state that raised this issue that we are not listed in the US job classifications. So it's the first time all of these folks have worked together on one issue, and we're going to make sure that this happens.
Thank you, Sandra. And thank you, Tracy.
Can I make one correction? Yeah, it's 120 hours of education, not 175.
Oh, okay. You know what? That's my state. All right.
I thought Rhode Island probably, and that's a good point, because jurisdictions can add to the standards. So apparently Rhode Island has the education piece. So some states require a college degree, but it's not required in the ICNRC standards.
Right. The ICNRC standards require a high school diploma or the equivalent.
Yeah.
Thanks,
Thank you.
Julie.
Thank you to all three of our panelists for kind of opening us up and getting the conversation started. Sandra, thank you too for addressing that first question about the Department of Labor classification, so that we know that was a question asked in the chat. Another question, what if I am living in a, so we know ICNRC obviously has member states, and that includes states in the United States, but also includes other nations. But what if I am living and working in a nation that is not a member of ICNRC, and no one around me is either? What would be your guidance there?
Actually, I just had this situation of someone who lives in the Maldive Islands, and I recommended to that person that he contact a stateside board or Hawaii. All right, and either one of those, because they don't have prevention certification right now, they can actually go through an adjacent board. So there's nothing adjacent for the Maldive Islands, but I did West Coast and Hawaii were two options for that person. Right. So it's, yeah, and you can contact ICNRC or Marissa, and Marissa would be able to help the person identify an appropriate jurisdiction. And we call them jurisdictions, not states, because it could be the military, it could be a tribe.
Excellent. Thank you.
Sandra, following on that question, Fatima, she writes that, for example, now that you give an example of the Maldive Islands, she says she's a counselor in Nigeria, and how would she go about prevention certification?
So she would contact the ICNRC or Marissa, who's our chair of our prevention committee. She has a different title, but that's what it is. And we can make a recommendation as to where Fatima could go and what would be most appropriate based on language, for example. Obviously, you're speaking English, so we'd refer you to a country or a board that on stateside that would work with you.
Thank you, Sandra.
We have internationally, we have Bermuda, we have Canada, we have the Pacific Islands, we have Greece, Malta, that have the prevention credential. We have other countries that have the ICNRC counselor's credential, but not the prevention credential. So not all jurisdictions offer all of our credentials. They may just offer 2 or 3. So that's our international piece.
One of the things I'd encourage folks to think about as well is if you are in a jurisdiction that currently isn't an ICNRC member, doesn't offer some type of prevention certification, is can you be the change agent to get the ball rolling on that? I was a very, very young professional in Ohio when in 1989, when we adopted certification, prevention certification. So I was there for the experience. I wasn't one of the ringleaders making that happen, but it happened because prevention professionals in our state said this is important and we need to professionalize the field in our state, and took the reins for that. And as Julie, I think you stated earlier, Sandra, one of the two, we are kind of fortunate enough right now to be the largest jurisdiction in the number of credentialed prevention professionals. So that happened because of the work of prevention professionals in our state, folks who were providing direct service, supervising prevention programs, et cetera. I wanted to take a step back a little bit and ask this question as well, because we know that certification is in some ways an end result of what we just talked about, a little bit of advocacy and getting the ball moving around making that happen. That only happens when folks recognize that as a need. And so I wanted to hear from each of our panelists, or any of you who would like to respond anyway. What do you feel like needs to happen to gear up either the systems or the general public's motivation to professionalize prevention, whether that's adopting or increasing the number of people who are receiving the credential, whether that's creating degree programs, whether that is making prevention a legitimate career. What are some of the things you think need to happen for us to create the readiness, if we're going to use a SAPS term, create the readiness for folks to understand and recognize prevention as a legitimate profession?
So I see that Joanne said, hi Joanne, marketing prevention is needed. I'm a little even stronger than that. There's either a carrot or a stick. All right, the carrot is that I get a credential, I get letters after my name, and it validates and verifies the fact that I've been trained, that I have experience, and that I've had supervision in a legitimate field. But our experiences, and Julie and Marissa can comment on that, if a state requires certification of their funded providers, then it happens. And I've worked long and hard in my state to make that happen, and I know Julie has as well. So that if in fact I'm going to be, in the case I've made, is if you want evidence-based practice and you want good prevention, then people have to be trained in order to do that work. So in my state, within 2 years of accepting a paid position as a prevention professional, you must be certified. So they have the ICNRC certification. And I don't think it happens otherwise.
I had this conversation with Fran Harding when she was director of CSAP. And she said, I'm like, well, why doesn't CSAP require the jurisdictions that they give block grant money to prevention block grant money to have a certified workforce? And she said, it's about value, that the prevention credential isn't valued. And I was like, oh man. And so Sandra's right. So CSAP couldn't make that requirement of their block grant recipients. But Sandra's right, the state itself can. And in many jurisdictions, many states do, like Sandra's. Texas requires the CPS of program directors. And then we have another level, entry level, which doesn't require the exam. We have an entry level called Associate Prevention Specialist, which every direct service provider in prevention must have. So it's a career ladder. And so the entry level is the Associate Prevention Specialist, and the next, which is not reciprocal. And then the Certified Prevention Specialist, which is reciprocal. And they also have a third level in Texas, the Advanced Prevention Specialist, which is also reciprocal because it's the same exam. It just requires a degree and it requires more education and more experience. So and I, you know, many states have a career ladder and more than one level of credential.
But only one is reciprocal, usually, or the advanced and the
Right.
CPS is
Right.
reciprocal. The entry level is not reciprocal in any state.
That's correct, because unless they take the exam, but in Texas, they don't take the exam, so it is not reciprocal. And it's funny because I had, when we in Texas were creating this first level, so I was on the committee that helped create the associate prevention specialist. And then I got a question from the state. So I was working with the state people to provide it. Well, then another state staff person emailed me and said, how do we know that people with the associate level are competent? And I wrote her back, I said, we don't, because they haven't taken an exam. There's no measurement, because the exam is the vehicle by which we measure competence, because we've done such a huge, lots and lots of work on making sure the exam is actually, it's legally defensible because of all the detail that we have to go through using subject matter experts and data analysis and to create the exam. So
in the chat box, Natasha asked, and Marissa answered, you know, she's in a program, a degree program, but how does she get her 120 hours of supervision? And the response, and I did mention it, and the member boards, the member directory is on the ICNRC website. You would contact the board where you're doing your prevention work, and they would give you the qualifications for supervisor. In some states where there are few people certified as prevention specialists, it can't be a certified prevention specialist, but in my state, it has to be someone who has some prevention background that they document in order to be a supervisor. But every state is different. They have their different supervision requirements.
for example, Texas is very loosey-goosey. You know, your addiction program director, your executive director, your board, you know, can supervise. But in states like Arkansas, there's a specific person who is a certified prevention specialist that must do the supervision. And if you have, you know, you must have 2,000 hours of work experience. And so that's the setting for your supervision. So whoever supervises your 2,000 hours of work experience can document your supervision.
And I think one of the key things that, and I know Sandra and Julie, you both said this repeatedly, but just to underline it, there's the baseline expectations of ICNRC, and then folks need to really look at their jurisdiction, their board, to determine what the additional requirements are, because that can get a little more specific based on the jurisdiction. So very true. I got a private question from someone, and this is aimed at Tracy, asking about NPN and whether the states and the state directors through NASADAD, or again, the prevention leads, are there conversations about increasing degree programs in the United States, or any advocacy towards that effect?
Well, we're not an advocacy organization, excuse me, but we did have a webinar about that, highlighting, I think it was Alabama and Rhode Island, some of the efforts there. But we do different things like compile information about, you know, what states have those type of programs, things like that. But I mean, I think we're not the organization to advocate for something like that.
Tracy, who would you see as just as a follow-up, who would you see as the entities that should be doing that work?
Oh, I don't know. I mean, I don't know if it would be a state by state, you know, because I don't know how to do that.
Yeah, that probably makes sense. That it would be a state, or even, again, if we're looking internationally, country-specific or nation-specific entities within those.
Yeah, because I'm sure there's a lengthy process to go through within a university or within a university department. So I think it's maybe, targeting in your state kind of a flagship university, or even community college or, system, and just finding the appropriate department and meeting with a chair or, somebody like that. So I'm not sure who, but maybe a key stakeholder.
And
Yeah. Hi, everybody. The Society for Prevention Research has been advocating for master's and doctoral programs in prevention science. And there's somewhat of a list. Unfortunately, it's only through 2019, but I know that there are several other universities that have come on board with programs in those areas. So that's the Society for Prevention Research. You can go on their website under training and see. And for those of you who would like to work with developing a program, perhaps in a local community college or university, you might contact the chair of the training committee for the Society for Prevention Research. I think that might be a good way to go.
And we'll put the links to the Society for Prevention Research in the chat box. I assume we can do both the US and the EU as well. Great, excellent.
There's a couple of questions I saw, if you don't mind, in the chat box I'd like
Right ahead.
Yep. One is from Susanna, who says that when I was talking about legally defensible exam, does that mean that there are liability concerns with licensure? It's not a license, it's a certification. And the example, and we've never had it happen with the prevention credential, but the example I would give is that if somebody said, I disagree with the answer on your exam, answer number 75, where did you get that? Because of the rigorous way that we write the items, not out of our heads, but out of our resources, we can cite and we can say the answer to this is on page 7 of the CADCA manual about evaluation, which is on your list for study, your study list and your reference list. So that's why when we talk about legally defensible. And then there was one other, Tammy asked, do you have advice for jurisdictions that would like to adopt an assistant credential below the reciprocal? Yes, if you can email me, we have a matrix and I'd be happy to send you the matrix. And this has all or most of the jurisdictions that provide the prevention credential. And then we have all levels that they provide. So it would say Texas and it would say associate prevention specialist and give those requirements. And then the CPS, which is reciprocal, and give those, and then the advanced. So if you want to, and I know you, Tammy, if you want to email me, I can send anybody that matrix.
So Barbara's question, it says, for me, prevention is prevention. I agree. We've had this conversation at the ICNRC level. So we feel that our certification is a broad certification with a substance misuse prevention focus, all right, or behavioral health focus. So what about expanding the education requirements? The education requirements are just the 120 hours. The state you can take any coursework within that's related to substance misuse prevention, which would be mental health and wellness topics, all right? So yes, we've had this conversation about the CHES, the Certified Health Education Specialist. We are different, and we actually have a sort of a chart which compares the two certifications. Ours has the focus on substance misuse, behavioral health, and there are other areas that we cover that are not covered in the. The subject matter experts are going to meet, look at the current job analysis, as Julie mentioned, and there are some topics that actually were recommended by the NPNs to us. Such as more information in there about social determinants, ACEs, adverse childhood childhood experiences, more on health disparities, and more on positive, benevolent childhood experiences. So those will be 4 topics we'll be considering. And if you have any other thoughts about that, what we should be thinking about, that will be a conversation when the subject matter experts are assembled to look at the current job analysis. So that because the field is always evolving, that's why we do this every 5 to 7 years.
And in our blueprint for our exam, which is in the prevention candidate guide, there are, I mentioned the 6 domains. There are actually under each domain, there's tasks, and under each task, there are knowledge, skills, and abilities that subject matter experts determine. There turns out to be like 58 tasks under these 6 domains. One of the tasks in the domain about professional growth and responsibility talks about you must have the knowledge of behavioral health issues. And we have exam questions about behavioral health issues. And this book is one of our main, it is our Bible. This is Preventing Mental Emotional Behavior Disorders Among Young People from the Institute of Medicine. So it does focus on behavioral health. And this is one of the main references that we write exam questions from and expect people to study.
A question for all 3 of our panelists. One of the things that I've long thought is that we can do some of this big picture work of really encouraging folks to get credentialed, obviously getting our jurisdiction to join ICNRC if they're not a member of ICNRC, connect with our NPN representative, et cetera, to ensure that we're getting good professional development of our existing workforce. I also think there are little things that we can think about. I'd be curious to hear your response or your thoughts on this. So for instance, I often will hear a prevention professional talk about, oh, I work at X organization, it's a treatment agency in our community. And I always like to correct folks and say, if you're doing prevention, then it's not a treatment agency, it's a prevention and treatment agency. And that we need to own our profession in some ways that we don't always do. And so I'd just be curious about thoughts that you all have about just that kind of positioning maybe, or smaller scale things that we can do to move the needle a little bit to help folks understand that we are a profession and that we're a legitimate profession based in science.
So I've definitely had that conversation. I've worked in recovery and I chair a statewide treatment program, but I will say to them, you're a behavioral health multi-service agency. You're not a treatment agency. You are providing services not across the continuum of care, in prevention, treatment, and hopefully in recovery. And in fact, that's the best way to go. And some treatment agencies might do, policy and advocacy work, which is part of what we do. They may not be doing all of it, but they might be doing a school-based program too, or they might have student assistance counselors on their team, which is not treatment. So I think we need to take the time to, qualify for people. I think as you implied, Jim, and say, well, actually, this is who you really are, So, and this is why, and then refer to the continuum of care. I don't know if my colleagues have anything to add.
Yeah, I agree. And I think that language matters too, and education and people, maybe young people need to be educated a lot sooner. I mean, everyone goes through health classes in middle school or early high school and learns about different aspects of health. And a lot of that, those lessons include around substances, and I'm just not sure what type of education. Even when during the, I guess there's still an opioid crisis, but there was a lot of attention focused on overdose prevention, which it was like, that's not prevention. In the true sense of the prevention definition and the work. So
Thank you.
yeah, so I know that the NPNs were trying to reshift that language to calling it overdose reversal instead of prevention. So there's just things like that it's important to stand up and just kindly correct people and change the language.
I've heard overdose mitigation as a potential alternative as well. So,
Right.
or relapse mitigation as part of that also. So.
There was another question about, and I posted the book in the chat box, and then Shannon says there's a place where prevention and treatment cross over. We're talking about indicated prevention. Can you speak to the way service system can be improved in communication? So this is what you're talking about, right? And this is in my book. So this is the Bible. This is page 67 in this book. So if you look and you'll see between indicated prevention and case identification, which is under treatment, there's a darker, heavier black line. That line indicates where the DSM-5 comes in, right? So we cross over into treatment. Once we get past that black line, we're in case ID. Indicated, so if you're not licensed as a counselor, then you don't go there. In indicated prevention, you certainly can do screening and referral.
And even if you are licensed, if you're wearing your prevention hat, you don't go there. So we can, we talk about expert. We can screen, we can ask them questions about someone's use and, whether it's affecting their life. We can do a brief intervention. I always say to folks, life can be better. You deserve to feel better. And then make a referral. So as a prevention specialist, I really need to know the resources in my community. But I'm trained as a counselor, but I don't do counseling when I'm doing prevention. I don't have that hat on. And so indicated prevention, it was people who are not yet diagnosed, but may be engaging in risky behavior. So what a student assistance counselor does, if they're doing their job appropriately, they're not doing treatment, they're doing an intervention program. And then Joanne asked, how would you explain the difference between credentialing and license? So we credential, you may have to help me with this, Julie. We credential a state office of license. There are no licenses given for prevention professionals, but in my state, you have to be credentialed before you're licensed as a treatment person. So a license is a legal designation set by the state with state requirements. In the best of states with counselors, they are perfectly aligned, but we don't license people in our field. We only certify, and the only certifying body that has a nationally defensible process, a legally defensible process, is the ICNRC.
Right. So I put the link to the book in the chat box.
Great. Folks, we are coming up on our hour. Wanted to take a last stab at any questions for our panelists, or panelists, any last comments that you would want to make about where we go from here?
Oh, okay. Yeah, there's a question about the Institute of Medicine continuum of care to include promotion. The first continuum of care was 1994, and it started with universal selective and indicated prevention. Then this one in 2009, 2010 added health promotion, and as the first little pizza or whatever you want to call that thing. But the newest one, which is 2019, and I thought I had it here. I'm gonna look in my office. Starts with health promotion, but it starts with 3 sectors, and it's like society, community, and individual health promotion. Then it goes into prevention, universal, selective, and indicated. So after health promotion, thank you. Oh, good, thank you. Everybody gets Susanna, way to go. After that, yeah, this is the new book. She's got the new one. That's when risk and protective factors are identified, and we start with universal, selective, and indicated prevention. So they continue every 10 or 12 years to take a look back at the continuum of care and update it. So that's the newest one, is the one that what's the name?
And Fatima asked if you can get the book online. Yes, both of them you can get online.
Right.
So you don't have to pay the, $100 or so that the book costs. It's, it's a big document, but you can download the parts that are relevant to you. Some evidence, yes. So, some states do pay for indicated prevention, others don't. That's definitely something we should be advocating for, I think. And the decision to redefine the continuum of care, as far as I know, Julie, you might be able to speak to that, or even better, Tracy. Just as a last question is, I think that was done at the CSAP level, and not anywhere else.
Oh, you mean the new one with the health promotion front?
Yeah.
No, that's the new version. That's the 2019 version of this.
That's right. It's in there. Right.
And it's from they call it now not the Institute of Medicine, but the Institute of Science, Medicine, and Engineering, or something else like that. But it is 2019. So if anybody wants to Google that one, you can find that one as well.
So Nicole has a good suggestion. She's trained a lot. She does a physical exercise where people stand on the continuum of care. If you draw that on the floor or put something on the wall, and it helps people sort of discern, where they are. So, okay.
Great. Well, folks, we have reached the end of our hour. So I want to thank you all for attending today. Particularly want to thank Julie Stevens, Sandra Del Sesto, and Dr. Tracy Flynn for being our panelists today. I am going to pull up my PowerPoint again, just to provide you with the URLs for ICNRC, for NASADAD, and Applied Prevention Science International. So you can, I know we put most of that in the chat, but in case you didn't get it as the chat flowed. Maria, I'll let you bring us home.
Sure. Thank you very much, all of you, for joining us in this prevention talk. It was definitely very rich, great conversation. Thank you again to our panelists. Thank you, Jim, for great moderation in this occasion. And don't forget to follow us on Twitter. We are at APSI_EC, where we put all the information. And also you can join our mailing list, so you can receive our prevention nuggets. That are pieces of information, very critical information for prevention science, that we put out every week. And if you have any questions, or you have anything that you want us to address through the nuggets, you can also email us, and we will be happy to work on a nugget to respond. And if there is any topic that you're interested to hear about in the prevention talks, we can also look at that and see if we can put together a panel and address also those interests that you can have. So again, thank you all very much, and we'll see you next month, where we will be talking about suicide prevention with a very special and a very renowned group of prevention professionals on that specific topic. So we'll see you soon, and stay tuned for the information about that prevention talk. Thank you very much.
Hey, thank
Thanks,
you.
everyone.
Bye.
Thank you, Jim.